Welcome you all to today's Indians program. From today on, we'll be starting geriatric services in our Indians. So every Saturday from today, except for second Saturdays, we'll have geriatric psychiatry team from NIMHANS who will be presenting many different topics and sessions on geriatric psychiatry. Today we have with us Dr. Shivashanker Reddy, who is the first DM candidate from NIMHANS in geriatric psychiatry. He'll be taking a session on interviewing and assessments in psychogeriatrics. And this session will be chaired by none other than Dr. Mathew Varghese, who is who is professor and head of geriatric clinic and services here at NIMHANS. So welcome you both, sir. So over to you, Dr. Shivashanker. Dr. Mathew, sir, do you want to put in a few, tell a few words before we start the programs?
Yeah, thank you very much, Chetan. And the Geriatric Clinic and Services is very happy to be associated with the IPS NIMHANS Indians program. And this modules that we're going to run for the next 12 weeks, going from starting from today all the way right up to December, every Saturday, is going to be a comprehensive evaluation and management of all common geriatric problems. So we'll be discussing, in the initial session, we'll be discussing about interviewing, assessments, structured assessments, and then we'll move on to things like looking at assessment and management of elders with depression, with dementia, with other psychotic disorders, with bipolar disorders, and so on. So for today's session, today's session and the next session, 2 weeks later, is going to be basically on psychiatric, neuropsychiatric, psychogeriatric interviewing, assessments, and all the structured scales and assessments that we're going to do. So I would ask Dr. Shivashanker Reddy, who's completed his DM in geriatric psychiatry just a few months ago, to do this presentation. So the presentation will go on for about 40 minutes or so, as you usually do, and then we'll throw it up for discussion right at the end. We'll have another 15-20 minutes for discussion right at the end. Go ahead, Dr. Shivashanker.
Yes, sir. Thank you, Dr. Chetan and Professor Mathew Varghese. Yes. Dear postgraduates and also educated psychiatrists, today our session will focus prominently on assessment of older adult population and about the mental health issues particularly. We are going to take you through the process, how the interview happens, and also what are the standard structured assessment available in this field. Yes. So the objective of the presentation is today, does older adults assessment is different from usual? What is comprehensive geriatric assessment? What are elements of comprehensive geriatric assessment? What is the evidence for comprehensive geriatric assessment? What are other structural assessment available, such as GMS and ICE and CIRS, which are geriatric mental state examination. One is instruments for comprehensive evaluation elderly. The last one is clinical illness rating scale for geriatrics. So we take to the case vignette. Just we read about it. A 70-year-old Mrs. Q, who lost her spouse 6 months ago, is brought by her son with complaints of recurrent falls. She lives on the top floor of a 3-storied building, and since 5 months, she became withdrawn and lost her weight. Her medical illness includes hypertension, diabetes, osteoarthritis, and past history of stroke. She has stopped using her hearing aid also recently. She stopped getting essentials and visiting religious places, which are 3 kilometers away from her residence. Recently, she also had difficulty in affixing signature. The son came to you and requested you for your guidance for placement. So these are the kind of cases you will be seeing in your busy clinics or inpatient setups with these kind of problems. So we'll come back to it later again after completion of the structured assessment, how she can be helped. So what is unique about older adults? The older adult treatment is not just medical management of any psychiatric or physical illness. It is more than that. Usually they come with multiple comorbidities. Studies done in the West report that approximately 70 to 90% people have one or other comorbidities. Studies that done in India on depression cohorts reported up to 76% of having medical illness, and 36% of these people have more than 3 medical problems. In one of the study done from Chandigarh, they report that 88% has medical problems and 42% have 3 medical problems. So they have higher medical comorbidity than adult population or any other population. And the other thing is that the presenting symptoms of illness may not always be source of primary process. For example, you take a delirium, for example. The person might come with agitation, they come with hallucination, they come with sleep disturbances, but the origin of the cause for these symptoms can be metabolic disturbance, can be infection, can be a subdural hemorrhage. So there's a varied etiology presenting common symptoms. So so in this way they are unique. There are also sensory issues. So these are one of the difficult issues to sort out in elderly, but however, majority of people have one other sensory issues. In a study done in South India, they reported that 72% have hearing issues and 48% have sensory issues among the elderly population. If you take dual sensory impairment, I mean both hearing impairment and visual impairment, 32% have both these problems. So in this way, they pose a unique challenge in terms of assessment and also management. The other psychosocial issues include in terms of the retirement, life events such as bereavement, migration, they may be staying alone or changing economic status. So all these things, psychosocial issues can also play a major role. The other is the caregiver issues. So this is a field where there is a lot of caregiver is required and also going to be demand. So caregiver includes both formal caregivers and also informal caregivers. So in terms of by not addressing the caregiver issues, we also will not improve the quality of life and also we address the needs of elderly people. So caregivers are an important part of the geriatric assessment. And also there are syndromes called geriatric syndromes, which are more common in elderly population. And we will take you what is geriatric syndrome. So for management of or assessment of elderly requires integration between physical health, functional abilities, psychological health, financial and psychosocial factors. So what are geriatric syndromes? We'll tell you briefly about it. So though it is a topic under geriatric medicine, as a psychiatrist, you do see these syndromes in people you cater to. So these are nothing but clinical conditions in older adults that do not fit into discrete disease categories. Another way put across, these are multifactorial health conditions that occur due to accumulated impairment in multiple systems. So there are well-recognized there are 6 geriatric syndromes are there that includes delirium, falls, incontinence, pressure ulcers, functional decline, and polypharmacy. So these are well-recognized entities. They don't have a single etiology. These are multifactorial and they may occur because of multiple cumulative effects of independent conditions also. So these require comprehensive evaluation, I mean to say. So how can elderly geriatric syndrome frailty and poor outcomes are related? So you see elderly population, they themselves have a lot of risk factors in the form of elderly age. They have a compromised pharmacokinetic and pharmacodynamic systems. They also have issues in the form of sensory issues. They also have adverse psychosocial issues. They're all shared risk factors. So with this thing, they can have a risk of geriatric syndromes like fast, delirium, incontinence. And these risk factors also predispose to cause frailty. And geriatric syndromes will also increase the tendency to develop frailty. What is frailty? Frailty is a condition where there is a decreased reserve and increased vulnerability for day-to-day stressors and acute events. So in this state, people are more prone to diseases and more to fall ill, and they may develop dependence or disability and mortality. So all this will lead to higher poor outcomes in the form of disability, institutionalization, or mortality. So there's a shared risk factors, and there are also bidirectional relationship between all these outcomes. So by addressing at least few of the risk factors and few of the syndromes, we can reduce frailty and thus poor outcomes. So brief history about geriatric assessment, so which we are talking about now. So how they are developed actually. So we know we usually follow Mayer-Grass pro forma of standard assessment of psychiatry. So how it is evolved. So geriatric field, though it is slightly newer to our Indian setup in terms of geriatric psychiatry, but it is developed well in 1930s and 1940s itself. So Marjorie Warren is a geriatrician when she was working in a specialized geriatric assessment unit in Britain. So she come across a lot of patients, nursing home residents, she come across who have undiagnosed illness. And when she tried to address these things, many people got better and they're able to manage themselves independently. So simultaneously in 1930 to 1975, Rubinstein, who was working in Sepulveda near Los Angeles, he's also a geriatrician, physician who was posted there. When he found that, and he found out of out of our residents, every person at least 3 or more undiagnosed medical problems or in psychological issues. So when you try to address these issues, majority of them can be managed on outpatient basis. They could be discharged and they can be independent. So these key findings made them develop that, okay, we need to assess them properly when you are admitting into nursing home residency or institutional setup. So this led to development of geriatric models such as comprehensive geriatric assessment. So after landmark RCT in 1984, CGA become norm for all assessments of geriatric in terms of outpatients or inpatients, in terms of nursing home settings. It becomes a standard assessment for all the elderly population. In 1990s, there is advancement of the CGA, which is a minimum data set, which is kind of like a insurance companies. We have to fill this data set, which has 400 items. All the people who are admitting into any institutional setup will have to go through this procedure, and this has to be repeated. So this helps in maintaining the quality of health checkups, quality of care also. And there's a wide evidence for the minimum data set as well. So what is comprehensive geriatric assessment? So this is a term which most associate with geriatric medicine and less with psychiatry, but more and more as a psychiatrist also we should be learning these techniques and also including these principles in our assessments for elderly care. There are synonymous terms like comprehensive old age assessment or geriatric evaluation and management, which are COAA and GEMT. CGA is a multi-dimensional, interdisciplinary and diagnostic process. So the goal of CGA is to identify care needs, plan care, and improve the outcome of frail older people. So this is the definition and this is the motive of CGA. So what is rationale behind comprehensive geriatric assessment? Why should we do comprehensive assessment? As I explained, so elderly population have undiscovered treatable diseases which only will be surface or which can be uncovered only by detailed evaluation. There are also possibilities of premature and otherwise avoidable institutionalizations, also the increased disability in older population, and widespread neglect of rehabilitation needs, inappropriate drug use and polypharmacy, and iatrogenic problems among older people. So all these are reasons for us to take to assess older adults comprehensively in every aspect, so that we can address these issues. These are things which can be addressable. So the principles of comprehensive geriatric assessment includes it is multi-dimensional in the way that it doesn't include only one particular aspect like physical or mental health. It includes all the domains, including physical, mental health, environmental, financial. So every dimension has to be assessed. Systematic. So it includes a detailed assessment of every possible domain. It is multidisciplinary. This is a term which can be applicable people who have multidisciplinary teams, but doesn't say that it is only multidisciplinary team. It even a single psychiatrist or a resident can do this assessment in a staged manner. So like a mental health professional, a social worker, a nurse, dietitian, occupational therapist, all can be involved if available. Otherwise, you can also do it independently. This is a coordinated, specific coordination should be there between the people who are actually evaluating and have a dialogue and a particular goal. It is a diagnostic, also treatment process. It also improves diagnostic accuracy, and also it helps in treatment process as well. And with the help of specific measurement instrument, we can also bring objectivity and quantify the disability or quantify the illness. So what are the 4 major elements of CGA? So as we spoke in that, it involves a multi-dimensional assessment. So what are the key dimensions of comprehensive geriatric assessment? These include physical health assessment, mental health assessment, social and environmental assessment, and functional assessment. So we'll talk about how to assess these particular domains. It is not limited to these 2 things, but there are the main domains, elements which has to be taken into consideration. So there's also articles why these only 4 things should be assessed. So when they did the studies, they found that these health status, socioeconomic environmental factors, disease state, and functional status has a direct relationship with quality of life. So if you address one issue, it may not improve the quality of life, it may not improve the functioning as such. By addressing all these things, there is high likely chances that the quality of life and also functioning will improve. So this is the reason why we had to assess these 4 domains. So individual components of these domains. So if you write down, pen it down, list of things which are to assess, it may fall in this category like functional capacity assessment, fall risk assessment, cognitive status, the mood status, the polypharmacy and inappropriate medication, nutrition and weight changes, continence, chronic medical illnesses, sexual function, vision and hearing assessment, dentition, living arrangement, social support, financial concerns, spirituality, and advanced care preferences and nominated representative. All these things has to be assessed if you put it down. So for the sake of assessment, you can organize the assessment into these categories. Okay, you do these assessments in particular domain so that you don't miss out anything. For example, under physical domain, you can assess comorbidities which are common like hypertension, diabetes, or a cerebrovascular accident or medication review, and you can assess whether they're managed or how long they are there, how severe are they, what is the impact of these medical illness on the functioning, on the disability, on the overall quality of life of the person. And also by doing medication review, we also know what is inappropriate, what is appropriate medication, what is the dosage is required or not. So all these things can be taken consideration. So it's always ideal to ask elderly person to bring the medication kit and show them than actually telling him orally, so that you know exactly what tablet he is taking, what quantity, and how many times he is taking per day. So this is a pill box. You can just bring a pill box and do a proper checkup of everything, so that you can remove. The duplication is also one of the major problem in older adults. Duplication of medication from multiple specialists they give. There's some overlapping prescription, so it is a major problem. So all these things can be addressed. In terms of mental health, so mental health issues are also important contributor for morbidity and poor quality of life. By assessing anxiety, depression, cognitive status, or it can be loneliness, it can be social isolation. So all these factors can help you in improving the quality of life. So these things are may not come in single interview, but you have to assess it multiple times in a staged manner, and put it across in a simple terms to elderly population. You may be able to address, and you may bring out these issues and you can address it. One of the major issue in elderly is grief. So unresolved grief, empty nest syndrome. These are other psychological issues in elderly population which needs to be addressed. Functional capacity, how to address functional capacity? So you can ask the person when the last time he is doing all activities, or he's holding a proper job, or he's taking all responsibilities in one way. The other way is asking easiest is there what he will do, how he will spend 24 hours in a day. So describe his 24-hour routine. So that will give understanding about his functional capacities. We can also use some instruments which I will be talking about a little later. So along with that, you can also assess activities, exercise, gait, balance, all those things need to be assessed. So other things like psychosocial assessment, which is also important part. So whether they belong to any kind of like any social support they have, what kind of social network they have, what are the economic factors they have, who are the caregivers available potentially, what are the help available to them, what are the living arrangements they have. Along with that, what are social welfare benefits they are getting. So are there any difficulties in getting those things? So all these things will help. So all this will help you in terms of planning them, and also in organizing rehabilitation also. In terms of environment assessment, this is important in terms of like as international classification of function describes, environment modification important thing. So environment should not be a barrier for full functioning of elderly population. In that way, you can assess what is facilities available to them, what kind of setup they are living in. Is it elderly friendly, or it has barriers? It kind of staircase having, or it has to climb 3-4 steps. Railing is available or not? Slippery surfaces are there or not? Means slippery surfaces which are not good for elderly. So all these things can be taken. The transport facilities, elderly friendly transport facilities, separate queues are there or not? So these kind of assessments also helps you to think what kind of environmental measures or friendliness available to elderly, so that it has an impact on functioning. It also impact on disability itself. So this is a summary slide. I mean, what all we discussed. So if there is a multidisciplinary team, we can allot specific domains to a physician to address physical issues. A mental health professional can address mental health issues. A social worker can address socioeconomic and financial issues. And visiting nurse or occupational therapist or a person can assess the environmental factors and assess the disability and friendliness of the thing. Other specializations like dietitian, ophthalmologist, ENT specialist, neurologist, speech therapist may be required not in all patients, but specific patients who require that. For example, patient with stroke require with a Wernicke's aphasia may require speech pathologist. Okay, with a hemiparesis may require occupational therapist. Patient who have a hearing problem may help from a ENT specialist. Poor appetite and weight loss is there. He may be helped by a dietitian. So all those things can be liaised when there is a need. So all these things doesn't mean that there is a multidisciplinary care. Even a mental professional can do all these assessment at primary level himself, and then depending on the need, he can liaise with other specialists, but isn't barred from evaluating by a mental health professional from all these conditions, even physical health also, chronic medical illness, socio-economic factors, environmental factors. All mental health professionals should attempt and should also have the curiosity to assess all these factors and address it as much as possible. So some of the instruments which we usually do, these are not mandatory to be used, but these will add to your quantification also to give objectivity of the findings you have found in your history and evaluation. So how do you assess? You assess basic activities of daily living, whether he can do activities or not. There are only 6 basic activities which you can ask himself also. Same thing are reflected in the CAL scale, and EASY is a everyday ability scale for Indians developed for Indian population, which includes like feeding, bathing, dressing, toileting, transfer, and continence. So these 6 things you can assess it. In terms of instrumental activities of daily living, Lawton scale describes eight domains, which includes like shopping, telephoning, laundry, housekeeping, meal preparation, management of medication, and these things it will cover. In terms of social support, there are many scales. One of the commonly used scale is social network scale by Lubin et al., which has a long version, just short abbreviated version, of 6-item version is there, which gives you where are the relatives available, the nearest available relatives, how often you visit them, how often he has the meetings. So all these things will be assessed through social network scale. There's a mental health also. There are many scales, PHQ and patient health questionnaire and geriatric depression scale assess depression. You can also use geriatric general health questionnaire also you can use. For cognitive assessment, we can use mental status examination, Hindi mental status examination, and 88-8 is a informant questionnaire, screening questionnaire. These are all screening questionnaire for the cognitive status. Depending on the impairment, you can go through further assessments. You can go through bedside assessments also. So for mobility, gait, and balance, the commonly used test is get up and go test, which is kind of like you ask an elderly person who is seated in a chair to get up and walk 3 meters and return back and sit in a chair. So generally the cutoff we will take is 13 seconds to go 3 meters and come back and sit in the original position. If it is more than 14 seconds, we say there is some impairment in gait and balance. So to have more detailed assessment, you can do a TNT performance oriented mobility assessment, which assess the posture, which assesses the balance, which assesses the gait. So there are 3 domains. You assess some domains in sitting position, some aspects in standing position, some domains when you ask him to walk, and then you assess. So you give a scoring. So the lesser the score, the more disability he has. So more he has impairment in terms of mobility. So that require assessment in terms of like physiotherapy, or in terms of like what is neurological condition, or he has a musculoskeletal problem. We have to address those things. In terms of nutrition, so sarcopenia and weight loss is one of the major problems in elderly population. This can be multifactorial. One thing is that they may lose appetite. The other thing is they may have poor dentition. So all these factors, along with that, they have depression. Along with that, they have difficulty in swallowing, medical illnesses. All these things contribute to weight loss. So addressing the weight loss is an important factor in managing elderly population. So you can have a structured assessment like mini nutrition assessment, which is very simple, which is 6-item scale. How often you eat, how much protein you take. So all these things includes whether you feel appetite or not, how much weight loss was there in the last 3 months. It all takes into consideration. I will show you a few scales which I have after the presentation is over. So you can go through some of the domains. So what is the use of comprehensive geriatric assessment based on settings? So people think that it is just based on only hospital settings. No, it has been evaluated. It is possible to assess in every settings. For example, it can be suitable for acute geriatric care units. It is also suitable for inpatient consultation, for outpatient consultation as well. Also, while you are making a discharge plan, you can also give this plan so that whenever he comes back, you can do this assessment on outpatient basis as well. Or else also possible in home visits. You can do some assessment at your clinic. Some assessments can be a home team can go and assess environmental factors or financial factors, economic factors or social factors, all those at home itself. In a nursing home, geriatric assessment also is possible. So who is likely to benefit? Yes, as we talked about, elderly population definitely going to benefit. Along with that, middle-aged people who are also having medical comorbidities, psychosocial problems, specific geriatric conditions as I described as delirium, functional decline, incontinence, or frailty, these people are also going to benefit. And people who are likely to have high healthcare service utilization or who already coming for multiple admissions, this is beneficial. So what I found is that rather than having, so as world is moving towards community treatments and outreach facilities, the inpatient care is becoming more costlier and is a service, it is highly service oriented. So what I mean to say is that rather than having multiple many admissions, we can plan one good inpatient admission which I can thoroughly assess all the factors. Then we can plan for a community assessment and treatment later. So this will decrease the healthcare utilization. It also help in avoiding logistics of bringing patient off into the inpatient care. And consideration when it's also beneficial when you're considering a change in living situation. For example, from home setup to nursing care, from home setup to residential care. So these things will particularly help in assessment so that this will not be ignored later again. So what are the benefits of comprehensive geriatric assessment? Definitely it is going to improve diagnostic accuracy. It reduces hospitalization rates. It reduces institutionalization rates. It reduces inappropriate medication use. It improves quality of life. It also improves cognitive and functional status. It decreases mortality rate. It also reduces medical care cost. So it has several benefits in following this kind of comprehensive geriatric assessment. So it not just limited to health benefits, it has a lot of benefits in terms of financially, it has benefits in terms of functioning, it also benefits in terms of mortality rates. So when it comes to evidence, CG has a robust evidence in terms of RCTs, meta-analysis. There are studies all the way from 1984 to 2017, systematic reviews and meta-analysis. One of the landmark meta-analysis was done by Stuck et al. 1993, which have quantified the benefits. In terms of it actually reduced 18% of mortality who are there in the CGA program. There is a 25% reduction in 25% likely chances of living at home. There is also 45% increased chance of cognitive impairment. There is also 12% reduced risk of hospitalization. So there are several benefits, even quantifiable benefits are there. The similar findings were being reported by Elkan et al., Van et al., Stuck et al. Again redid analysis in 2001, 2002, and Ellis et al. In 2017. There's also one more study done by Rubin et al. In 1995, which also reported multiple benefits of comprehensive geriatric assessment. So evidence from India, though we do address things in psychiatric patient, it is not comprehensively assessed, and there is no interventions. These interventions studied at a research level. So one study we found from Bangalore, from a geriatric community medicine setup and geriatric medicine setup, where 70 older adults are assessed using comprehensive geriatric assessment. They found that it helped in uncovering geriatric syndromes and mental health issues in this paper. But it is a study of small sample size. So there need to be more studies of this intervention in Indian setup. Along with that, so now we completed the comprehensive geriatric assessment in our topic. Now we move on to some assessment, some structured comprehensive assessment in our Indian setup. So one of the assessment is ICE, which is nothing but instruments for comprehensive assessment, comprehensive evaluation of elderly. So this was developed at Geriatric Clinic and Services at NIMHANS. It was developed basically for outpatient screening assessment of older adults. It is a quick multi-dimensional assessment. It assesses all the domains which I told you, and in a quick manner, and it also helps triage the older adults to respective specialties. It may not itself be a very detailed assessment, but it gives idea about what are the major problems and highlight the red flags. Okay, these need to be assessed. The components of ICE include general health questionnaire, which has 5-item GHQ. It is developed from GHQ 12 only. Only 5 items are taken for this. There is AD8, Alzheimer's disease 8-item informant questionnaire, which assesses the domains of orientation, memory, judgment. So any of 8 questions, if anybody comes positive for 2 or more, they're likely that they have cognitive impairment. They need evaluation of cognitive impairment. There are another psychosis screen, which has ICMR 4-item questionnaire, which assesses the delusions, hallucinations, strange behaviors, muttering to self. So these 4 things it will assess. There is something called neurological screener, which was taken from Bun's survey study, which is 12-item assessment. It is actually a 3 subset questionnaire, which has the first set is also down details. The second set is nothing but overall population. The third is about children. So in the second subset, which are 12 items, it assesses the loss of consciousness, paralysis, any speech difficulties, any gait difficulties, any memory issues, any headaches, loss of sensory, any sensations. So these things it will domain. So it gives a checklist of all the things you can assess it in a busy OPD also. So the other is medical illness screening, which is cumulative illness rating scale for geriatry, which I am going to talk about after this. So which is also part of this this ICE. So by assessing all the things, you are able to come to conclusion that, okay, what is the main problem? Whether it is mental health, or it is neurological, or it is both, or it also has medical issues, or it is just common mental illness or severe mental illness, you can have idea. Depending on that, you can guide the treatment, you can triage the patient. For example, in our setup, which was, this is the model we used from 2008 to 2012. So last 4 years in our hospital, in a screening OPD for all elderly population, they go through this procedure. So as patient walks into clinic, older patient will be the older will be separated and they will follow a different queue, and they come to these our clinicians. They will assess through using eyes. If they identify the problem area, they make a provisional impression and they will make appropriate referral to a neurologist, neurosurgeon, a physician, or a mental health professional. And these things will be addressed. But many people may have more than one issue, so they all require collaborated or they require liaison kind of consultation. So next, coming to the cumulative illness rating scale. So what is this cumulative illness rating scale? Why it is needed for the mental health professionals? So as you know, elderly population have, many people have more than 3 or more medical ailments. So you need to have to cover all medical illness. You cannot do it by historically. So you need to have a structured or semi-structured assessment so that you don't miss anything, and you can also assess the disability and severity of each condition. So it is a short but comprehensive assessment technique of physical impairment. The SIDS provides rating of independent organ dysfunction. It was initially developed by Lin et al. In 1968. Later, it was adopted for geriatric population by Miller et al. In 1991. So it has 14 items. It assesses this cardiac status, hypertension, vascular, respiratory, eye, ear, nose, upper GAT, lower GAT, hepatic, renal, other genitourinary, musculoskeletal, neurological, endocrine, and metabolic. So all these 14 systems, 14 independent organ systems, you are going to assess, and you have to rate the severity and disability because of these things. So you come to a conclusion that, okay, depending on scores, you know that, okay, this person has a higher morbidity or higher body of physical illness, or higher chance of disability, and who requires intervention, you can target. So it looks like this. So the rating scale looks like this. So the rating will be the rate 0, which is past mild or childhood illness or no problems currently. Rate 1 means current mild problem or past major surgery or medical problem. Moderate means, rate 2 means moderate disability, which requires first line medication, which is controlled. Rate 3 is severe problem currently or causing significant disability, not controlled with first line medication. Rate 4 is extreme severe problem or organ failure is there. So you score all these things independently, and everything has a question, subset of questions, how to ask about it. For example, you want to ask about respiratory. So you have specific set of questions. For hemopathy, you have questions like anemia. So they have a subset of questions. So everything have 5-6 questions in the manual. So you can assess it and then you can rate it. So then the scoring will be the total number of categories endos, total number of score you get. The severity index, like total score divided by number of categories endos. It uses severity index per category, and number of categories at level 3 severity, and number of categories at level 4 severity. This gives how many categories you will be falling under severe category. So this will give an idea to the mental professional that, okay, this person requires to be in the inpatient setup, outpatient setup. This requires predominantly physical consultation. This person requires both. So you can categorize. You can also prognosticate the case by assessing in this way. So now we move on to psychogeriatric interviewing, which is a well-known geriatric mental state examination by Copeland et al. 1976. He developed it. It is a structured, comprehensive clinical mental health assessment for older persons. So we have assessments like mini scan for adult population, but we don't have a structured assessment for elderly population. And geriatric mental state examination specifically developed for elderly population. So it was developed in 1976, where there are present state examination was there in use and people are using that. But though there are certain things which are not suitable for elderly population in terms of higher organicity, higher medical conditions, which are not assessed through present state examination. But taking some aspects of present state examination and psychiatric status schedule and some added new items, they have come with the version which has 541 items of geriatric mental state examination. So it is extensively probes the psychopathology. It is a time consuming. So later they have developed a starter version called A3 and B3 version. The B3 version has 180 questions, which takes about 30 minutes. So what it will do? So the geriatric mental state will not give any diagnosis. It gives a psychopathology. It kind of like, it gives orientation, it gives your memory, it gives worry, anxiety, depression, or it gives about paranoia. So it gives the symptoms or delusions. So it gives these kind of symptoms. psychopathologically, and it rates the symptoms from 0, 1, 2, and 8 and 9. 0 is no symptoms at all. 1 means the mild symptoms. 2 means moderate to severe symptoms which are affecting their life. 8 means there are the person is not answering anything. 9 means it is not applicable, or you not applied the question to person at all. So in this way you can rate every item. Then by rating it, then you know this cluster of symptoms he has. Then later they have developed HCAT, which is the automatic geriatric examination of computer-assisted tomography. You feed all these whatever the scores you got in particular psychopathology into this system. It gives a diagnosis, and it gives hierarchical diagnosis in terms of so there are 8 main diagnoses which it considers. One is organicity, schizophrenia, paranoia, mania, depression, obsessive compulsive disorder, anxiety, hypochondriasis, and phobia. So it gives these 8 diagnoses. So there are many advantages of it because it gives a detailed evaluation of psychopathology. So what are the strengths of GMS? It is elderly specific. It is translated and available in multiple languages. It is used in landmark studies such as 1066 research. The structured interview useful for epidemiological as well as for clinical care. It tends to overdiagnose organicity, but is also relevant. I mean, in the sense that lot of conditions which are medically explained are present in elderly population. It makes more sense that you tend to overdiagnose organicity so that you can rule it out or you can address these issues. So now coming to the end of presentation, coming back to our case vignette I presented earlier. So 70-year Mrs. Q, who lost her spouse 6 months ago, is brought by her son. So with all these complaints. So by looking at this case vignette, we can highlight few things. We can list down the problems she has. One is she has recurrent falls, which is geriatric syndrome. She lives in a 3-story building, which is an environmental barrier to her to get down or to move about. She withdrawn and lost weight. Could be possibly a grief or could be possibly a depression itself. Her medical illness includes hypertension, diabetes, osteoarthritis, which are medical problems which need to be addressed. She also has hearing problems. She's not using hearing aids, which needs assessment. She stopped getting essentials and visiting religious places, which are 3 kilometers away from her residence, which is again an environmental barrier, which is hindering from participation in their activities. Recently, she also had difficulty affixing signature, so which has a legal aspect as well. So we need to assess cognitive status. We need to assess has any tremors. We need to assess any difficulties in writing or any in cognitive status. By addressing these things, we list out the problems, we categorize the problems, we address these systematically one by one, and if required, we can take the help of the other specialties as well. We can address these things. Does she requires placement now? So only by addressing all these things, we can, by quantifying disability, quantifying the dependency she requires, then only we can guide the son that she requires placement or not. So we cannot straight away say that it's premature that okay to just get a placement and then she can be taken care there. So these are the kind of issues we see, and we need to take a stock of all those things to address every aspect of elderly care. So take home message of my presentation is that older adults often come with myriad of medical, mental health, and social issues. Addressing only one aspect will not improve the functioning or quality of life in older adults. Comprehensive assessment is in a coordinated, phased manner essential in management. Geriatric mental examination provides comprehensive assessment of psychopathology in older adults. ICE is a quick, comprehensive screening instrument for older adults. So, as moving ahead, WHO declares as a 2020 to 30 as a decade of healthy aging and going to be coming out in October. So, as move ahead, we need to make arrangements for the environment, healthcare, and in health services to cater to this population, to foster facilities, and to make services more adaptable to elderly care. So, with this I conclude my topic. Thank you for patient listening.
Thank you very much, Dr. Shivashanker. It was a lucid presentation, and I hope all the participants have benefited by that. Now the floor is open for discussion and questions. We also have Dr. Mathew, sir. Sir, do you want to add some more things to the presentation, sir?
Hello, can you hear me?
Yes, sir. We are able to hear you, sir.
Yeah, so thank you very much, Dr. Shivashanker. I think we have finished well in time, so we have another 15-20 minutes or so for discussion. So I welcome comments from anybody or questions from everybody. Just want to highlight that the ICE, the what Shivashanker mentioned, which is developed here, is mainly meant for use by not specialists. It can be done by people who are just dedicated at bachelor's level or master's level, and your health workers or your project staff can use this for a quick screen of a comprehensive geriatric assessment. So ICE is something that can be used. It's been used for some epidemiological studies in other parts of India. We've circulated it. So it's not really of much use by core geriatric psychiatrists because we'll do a much more detailed assessment. But it's something that you can use in a quick study or in your screening OPD if you want to screen geriatric patients. Is something that you can quickly use. The geriatric mental state is the only comprehensive, structured or semi-structured geriatric interview schedule. So it's similar to, some of you might have heard of the present state examination of the SCAN, the schedule for clinical assessments in neuropsychiatry. So it's modeled on the PSC and the SCAN, and you have a detailed structured interview asking for symptoms of depression, mania, psychosis, hallucinations, delusions, disorientation, and so on. It's a very structured, nice interview which will go on for about 30 minutes or so. And if you use the GMS, you can say that you use the GMS just like you would use the full mini or the full state or the full interview instruments to say what is the diagnosis. So this GMS is something that just be used by a trained mental health professional. CGA, of course, all of you should get familiar with the CGA because when you assess geriatric patients, it's very important to look at these different dimensions, the medical, the mental and the cognitives, the socioeconomic status, the functional abilities, and so on. So it's very important to look at these things. And so I urge you to look at the CGA. I can see an addition by Dr. Gargi. She says one simple addition. The CIRS also takes into account malignancy. Yes, yes,
Yes, sir.
Gargi, that's right.
Yes, sir. It has slightly different rating. The rating which I presented slightly differ from the malignancy rating. But however, malignancy is also part of SIDS.
Sir, in YouTube there is in YouTube live there is a question by Dr. Akshay Nayak. Sir, please share ICE if possible.
Sure. Yes, sir. We have all the documents. I can.
We have the pro forma. How do we share it? We should. How do we share that?
Sir, we'll share it through the mails or we'll upload it in our Google account. Yes. So they can.
Similarly, Dr. Shivashanker has not put up the reference list. Will the reference list go separately or will it be?
It is there, sir. The reference list is there, sir.
Oh, it's there. I know you didn't show it. So.
Yes, sir.
So I want the students to have a look at the clinical practice guidelines that have come out from the IPS, Indian Psychiatric Society. The clinical practice guidelines came out 2 years ago. And in addition to a psychogeriatric interview, there is other chapters or other sections written on how to manage dementia, how to manage depression, how to do caregiver intervention, and so on. So it's good for students to look at the CPG, that is the Clinical Practice Guidelines of the Indian Psychiatric Society. Came as a supplement 2 years ago. It's a very useful supplement to look at.
Okay, sir.
Any other questions, please?
I'll show GMS. I'll just show the GMS, sir. How it looks like. So this is GMS. It looks like this. So the beta 3 version, which has 180 questions. So it goes like this. So the orientation item, it has everything. So you remember. So you can rate it like this. It's about worry. So it goes on like this: general anxiety section, depression, like. So under each category, again, there are 3 to 4 questions, sub questions it has.
GMS again is easily available from the 1066 Dementia Research Group website. So if you just Google 1066 Dementia Research Group, all the study instruments are there, and you can freely download the geriatric mental state, and then you can make a clinical diagnosis. You don't have the age-cat computerized algorithm, but that's all right. You can, doing a good interview, you can make your own diagnosis.
There is one more question in YouTube by Dr. Divya Agarwal. As a rule, should we use CGA on every geriatric OPD patient?
Yeah, so even if you don't use the CGA, at least if you have it in your mind that these 4 dimensions should be evaluated, it will be very important. You may not have time in a quick OPD to do all the 4 large areas. But at least if you keep it in mind that there are these 4 areas, and you must be mindful of what are the medicines that the person is taking, what are the what other illnesses does the person have, diabetes, hypertension, deafness or blindness, and similarly, what is the background? What is the background in terms of who does the person live with? Is there somebody to take care of the person throughout the day? What is the financial status? How easily can they access the hospital? These kind of things, if you look at, then you will not just simply assess the patient's dementia, write some medicines, give some advice to the caregiver and send them away. So you need to assess all these things. So it's very good to keep it in your mind that there are these 4 large domains, which is medical illnesses. Of course, mental and cognitive, we always assess as psychiatrists. We are very good at that. But paying attention to the medical illness, paying attention to the psychosocial issues, and paying attention to the disabilities, the functional abilities. Can they walk? Can they go to the bathroom? Can they brush their teeth? Is there a problem with balance and gait? So these are things that you must make it a point of looking at. So I would say yes, at least in your mind, even if you don't use a pro forma, at least in your mind, when you assess a geriatric patient, please do a comprehensive assessment. Other questions, please.
Are there any more questions? If people have questions, they can please ask in the chat, either in YouTube or in Zoom, so we can take those questions up. There is a question. I don't know who this Reddy is. Is there a training to use the assessment schedule like GMS? Can any mental health professionals use it?
Yeah, so just like you would require training to do a mental status examination in psychiatry, all of you, when you join a psychiatry residence, you learn how to do a mental status examination. You study psychopathology, you assess what is a hallucination as opposed to what is an illusion or a pseudo hallucination. So similarly, the GMS has a glossary. So it defines what are each of these terms. So it's a very structured, formal way of doing the clinical assessment. So you can do a routine mental status examination the way it is set out in the Maygra's pro forma. But if you follow the GMS, you will be asking questions in a very structured manner. You will not just go all over the place, and you will cover everything. Sometimes you might, if somebody's got psychosis, you might forget to ask about cognition. Or if somebody's got dementia, you might forget to ask about behavioral symptoms or psychotic symptoms. So it tells you to comprehensively assess everything. So there is a training, but just to use it routinely, you don't really need to go through the training. It's a good pro forma or questionnaire questions to see how you can ask these questions in the clinical situation. To do a study, you might have to undergo some training in GMS. And that's something that, we used to run trainings in GMS earlier on. We used to run trainings in SCAN and PSC earlier on, but after Mini became very popular, we've sort of stopped the trainings in SCAN. But it's something that can be done.
Yes, sir. To add on just yes, sir, to the person who asked a question. Yeah, if you see Mini and GMS,
How can you use some of these questions?
I mean,
Go ahead.
the way the questions are put across slightly different. These questions are put across for specifically for elderly. You see, many is slightly different. It will not be the way it was asked now. It's asked in a similar way. They will just the one or two questions which skips, and actually there are yes or no more questions. Here it will be like more like detail actually in terms of their own way to ask like that. So it's also culturally validated in our population. It makes more all the more sense to use this for the elderly population in our setup.
So there's a question here asked by Saroj Kumar Purohit. It says, how can we assess the scales and is this available online? Yeah, so the scales, the structured scales are going to be discussed by Dr. Gargi in 2 weeks' time. So she will go over details of the mini mental state or the Hindi mental state or the easy or the various other instruments that are used in geriatrics. Geriatric depression scale and all these scales she will go through. Most of the scales are available freely from the net. Some of them are licensed, so you might have to take permission to use some of them. But she will actually go through the scales in greater detail next time. Next session is purely meant for the structured assessments, bedside structured assessments. So we will cover all that in great detail next on the 19th.
There is one more question in the YouTube. Does ICE include any subset that evaluates psychosocial or caregiver support?
No. It's only meant for a quick screen in the OPD looking at medical, neurological, and psychiatric illnesses. It's screener, basically screens for psychiatric, cognitive, and medical illnesses. So it just does only the 2 dimensions of the CGA. Does the medical part and does the mental and psychological part. It doesn't do the other 2, that is the functional domain and also the psychosocial domain.
These are manual for SIDS if anybody want it. It is a 30-page manual, simple manual to use. So
I think Shivashanker, you can close that because we can send them the references of all this and people can look at it. It's all available on the online, so you can look at it. You can send the references in the. Just showing it like this on screen is not useful. Any other questions?
I think there are no more questions, sir.
Yeah. So, is there an opportunity for the students or participants who are attending to write in and ask questions? Is that also possible?
Yes, sir. They can mail us at psyacads@gmail.com. We'll take those questions and forward it to.
Yeah, please pass them on to us.
yes.
Please pass them on to me and Shivashanker, and then we can answer any of these questions.
Yes. The participants can also view this video in YouTube in our channel NIMHANS Indians. People can ask questions there also as comments. So those questions also will be taken up and we'll pass it on to the geriatric team. So there are two modes of asking us questions. We also have, there are actually 3 modes. There's also WhatsApp group that we have. So in the WhatsApp group also people can ask those questions and we'll get back to you with the answers.
So the WhatsApp group is only the participants, isn't it?
Yes, sir. The registrants.
So you'll forward the questions to us.
Yes, sir.
Great, that's great. I think it's a great thing that there's a constant learning process and questioning process. That's very good.
So any concluding remarks you would like to add on, sir?
No, that's it. I think this is just the start of the whole series. So we have 12 sessions. It will go on all the way till December. And I think if there's some particular things that all of you want, I think you can write in and say in advance. So if we need to include some things, we can actually include them in the sessions that follow. So participants, you can tell your other friends also that you can write in and tell us what you need. And according to your needs, we'll try and address all aspects of geriatric psychiatry. Thank you very much. Thank you very much to NIMHANS Indians. And we will continue with this. Thanks, Chetan. Back to you.
I thank Dr. Chetan for coordinating this and also inviting us for the invitation.
Thank you, Dr. Mathew sir, Dr. Shivashanker. We also like to place our sincere gratitude to Linux Laboratories, through whose academic grants we are running this program. Thank you, one and all. We'll be ending the session now. Kindly subscribe to our YouTube channel, NIMHANS Indians. You'll get all the videos, including this. We have about 50 sessions which have happened till now. So you will find all the videos in our YouTube channel. Thank you, one and all. Meet you after 2 weeks.
Somebody's asked for the email ID for queries. Deepika.
Yeah, I'll be.
Yeah. All right. Thank you. Goodbye.
So the email ID is psyacads@gmail.com. So you can get back to us over there or through our YouTube channel also. Thank you, Anand. We'll be ending the meeting for all now.